Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you're starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the state.
Children and the COVID vaccine. We hear a little bit more about it each day. At first, it was 18 and over who can get the vaccine. Then it was 16 and over, and we understand that there are clinical trials for younger children every day. What does this all mean, however, for families who have multiple generations living in one household? We are here this evening to discuss COVID vaccine and pediatric health. As you know, this is a live program, so give us a call with some of your questions. That number is 881-0013. This evening's program is underwritten by the American Heart Association, and we also want to thank the Texas Tech Paulo Foster School of Medicine for providing the medical students to man our phones. Today with us we have Madeline Morris, who is a first year here in El Paso. She comes to us from Dallas, and I said you will without question have better Mexican food here. So thank you, Madeline, for helping us out. We also want to say thank you to the El Paso County Medical Society for bringing this program to you each and every month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Okay. Once again, good evening. We are here with Dr. Glenn Fennelly this evening, and we are talking about what's happening right now in the world of vaccines. There were so many months we were just waiting for the vaccine to come. Then the last couple of times we had this program, we were just waiting for the supplies to come. It seems that that's really, really happening now. And by the way, El Paso is doing great when it comes to that. But the big question has been, and still kind of is, now 18 and over, that's been the thing, but 16 and over can get the vaccine. And they're starting to do clinical trials, and there's some approval that is happening from 12 to 16. So we'll talk about that in just a moment. But I'd like to give some background on Dr. Glenn Fennelly. He is the chair of pediatrics at the Paulo Foster School of Medicine. He's also the chief transformation officer at the El Paso Children's Hospital. And he has spent years in preclinical vaccine development, specifically in measles and HIV in children. So he understands the space of vaccines and understands the space of vaccines in younger people. So I'm thrilled to have you here. There are so many questions that I have, and I know that our audience is going to be calling in. So welcome, number one. And number two, as the chair of pediatrics, I don't want to go into what you do all day, every day. I kind of ask that of all the doctors, but I would love for you to talk a little bit about preclinical vaccine development, measles, HIV, and again, the whole new world that was kind of thrown your way, and just the understanding of that with now the COVID vaccines. If you can kind of just give a background about that.
Sure. I mean, we know that children are different than adults. They're certainly smaller, and their immunity, in some cases, infants may not respond as strongly to certain vaccines. On the other hand, their immune responses could be much more vigorous. So there are certain advantages to giving vaccines to younger infants. It's also an opportunity. As new vaccines come along, we can integrate that into the routine immunization, which pediatricians have done better than anybody for years.
And why is that? Why have pediatricians done that better?
Well, it's because it's part of what we do. I mean,
Okay.
and it's contributed to the eradication of smallpox and the control of measles in the Western Hemisphere, the eradication of polio in most of the world. So that goes back decades, and something I think as pediatricians we take pride in. We know that vaccines are the strongest public health tool that we have.
Exactly. Nicely said. So we've been hearing over the last several months, again, there is something that the FDA to provide emergency use authorization. So that's kind of a new world that we're living in today. If you can explain to the audience what that means and what kind of a process do they go through? Because even when there was a vaccine being talked about in November, there still had to go through a process. It's granted faster, but how does that work out?
Okay. So the emergency use authorization came into being after September 11th, and it was really intended as a way to get new products, vaccines, biologicals, which could be some of the monoclonal antibodies you've heard about, medicines that could counter bioterrorist agents. We needed a better approach instead of waiting 8 to 12 months for approval once the data was compiled. So first of all, you have to recognize this as an emergency, which COVID clearly is.
Absolutely.
Then the Secretary of Health and Human Services needs to declare it an emergency officially. That then gives the FDA the authority to approve under this mechanism.
Okay.
So the process can take a matter of weeks as opposed to 8 to 12 months for full approval. It has to be prefaced, though, on really solid data.
Bingo.
On a phase 3 clinical trials showing the likelihood that it's probable it may protect, while on the other hand, there's a high likelihood of safety based on what is known now. In the case of a COVID vaccine, the bar was set at about 50% effectiveness or efficacy to get approval, and safety had to be studied for a median of 2 months in subjects. So we got there pretty fast, and that threshold was surpassed.
Absolutely. So we have, and I'd love for you, and I know that's not one of the questions that we discussed, but I'd love for you to kind of talk about all these different, and not about the companies, but the fact that there are different vaccines from different companies. There's a little bit of difference between each, but that's just something that the world is new to. When you get the polio vaccine, it's kind of like, well, that's the polio vaccine. If you get the flu vaccine, well, that's a flu vaccine. With the COVID vaccine, it's like, whoa, what'd you get? Pfizer, Moderna, or AstraZeneca? You talked a little bit about biologicals. You also talked a little bit before we started here about mRNA vaccines and then adenovirus vaccines, et cetera. And I know I'm throwing that all out there, but in the space of how you work, and just the questions that I'm sure people have been asking you because they know your specialty, what are some of those questions and how can you explain some of those?
So first of all, the objective of vaccination is to, if you will, expose the body to a small part of a virus, bacteria, in the case of therapeutic vaccines, cancer, a small part of the cancer, to sort of go through the process of preparing the immune system or enhancing the immune system without actually getting in an infection. The big innovation with COVID vaccines has been the messenger RNA technology. The fact that you can manufacture a strand of messenger RNA, which in effect is a message to the cell to say, here are the instructions for how to make the surface protein of COVID. So it's simply put into a small lipid capsule in effect, injected, it's taken up by cells, that message disappears very rapidly, the protein is made, and that's really what leads to the side effects that many people are experiencing.
I would love to talk about that. And I said to you before the show, I have my first vaccine, don't have my second one. I was so excited that my body was feeling something because I felt like my body's doing something. Talk about that a little bit more, because some people are like, oh, the side effects, and it's a complaint. Talk about how it's really a great thing that your body is reacting.
Right. So, okay, and it's, I mean, the second major vaccine technology that's somewhat new is the adenovirus, which is a sort of a recombinant weakened virus that in effect just delivers a message or DNA of the COVID in a somewhat different way.
Okay.
So both of these are going to lead to side effects because your body is recognizing something that's foreign, something that's not self. And yes, as you mentioned, is this a correlation between the intensity with which we get these side effects and the response? It could. I think in time we may see there could be a correlation. So that in the balance is good news. Rest assured that those side effects go away after 2 or 3 days.
Absolutely,
in the overwhelming majority of people. They're very prevalent. Up to 80% of people that get the Moderna mRNA vaccine have pain at the injection site for a couple days afterwards.
Which is nothing for the protection, in my opinion. I'm saying that so out loud because it makes such a difference to people if it's just a couple of, sore joints a little bit, headaches maybe, tough it out, as you said. On that note, I'm kind of going to skip to this other question here. If there are any special preparations people should be on the lookout for, or what they should or should not do before actually getting the vaccine. So a lot of people have an appointment and they know what day they're going to get it. And some people are, hey, I got there at 5 o'clock, got it 10 minutes later, great. If you have time to prepare, what kind of preparations should one take?
Yeah, so no, first of all, that you shouldn't get any other vaccine either 14 days before or 14 days after you get the COVID vaccine. That includes influenza, shingles, pneumovax. For many people, that was sort of a decision. Do I get the flu vaccine first? Do I wait? We don't know what the interactions could be. Second of all, anticipate the side effects. So don't plan to do a triathlon in the days afterwards, after the first or second dose. And also, on the other hand, you don't have to take medicines to prevent those side effects. So avoid over-the-counter preparations for that. If you have to take them for other reasons, consult your doctor. It's probably okay. And if you do have side effects, maybe even consult your doctor after to ask them for guidance on that. If you take medicines that may suppress your immune system, it doesn't mean you cannot get vaccinated. It means the vaccine may not be as effective in you.
And so that's where you would consult your doctor and see if you would not take those meds for maybe a couple of days or whatever that would be. That's very nicely explains. Again, you hear little spots of information on that. The ibuprofen versus the acetaminophen. Again, it's more the idea that if you don't have to, it's better to kind of tough it out, so to speak. I'd like to talk a little bit about pharmaceutical companies, and they're working on emergency approval for use in children. So we talked at the beginning of the show, 16 and over now, I think is overwhelmingly accepted. And you were talking about a clinical trial with youth of 12 to 16 years old. I'd love for you to talk just about that and see where we might be futuristically for 12 to 16.
Okay. So the three vaccines that are approved for use in the United States are the Pfizer BioNTech messenger RNA vaccine, the Moderna messenger RNA vaccine that are based on very similar technologies, and the Johnson & Johnson vaccine that's based on the adenovirus, which I described.
Yeah.
The Pfizer has been approved for 16 and over since it got the first emergency use authorization because they had sufficient data to show that it's likely to be effective and that it's safe. The rich data for less than 18 from Moderna and Johnson & Johnson isn't there yet.
Okay.
Pfizer initiated studies going back to October where they enrolled about 2,200 children. They randomized them into placebo and getting the vaccine. And they announced through a press release last week that in the children who got the vaccine, there were no cases of COVID in a relatively short follow-up versus 18 cases in the placebo group. On top of that, one objective, the main objective, was to look at the level of antibody induced by the vaccine. Is it comparable to that which you see in adults that we consider to be protective? Good news is it was so-called non-inferior. And not only was it non-inferior, it was actually about 75% higher in this cohort of children. So based on this very exciting data, which also includes the fact that it was safely tolerated, there were really no serious adverse effects, so it's on par with what's observed in the older individuals. They're going to submit an amendment for emergency use authorization, and they anticipate that if it goes as they would like, then before the next school year, 12 to 16-year-olds could be immunized.
And that's such an excellent point. So we're looking at 12, and it's just me, I feel like I haven't heard much of 12 and under. So this whole, the elementary school, oh my goodness, and that's such a big group, and that's the group too where parents need to find care if they're not able to go to school, etc. Where do you, and again, this is, I respect that there's not a lot of information out there, but where do you see that being with the elementary school kids, so those 12 and under, within, let's say by the end of 2021?
Okay.
Let's make it out there.
All right, so the reason that the trials are progressing in this way, first of all, is that we do want to establish safety in somewhat older children.
Yes.
They're going to begin to look at lower dosing in younger age groups. Enrollment is already happening down to age 2 for the Pfizer vaccine.
Enrollment, repeat that if you don't mind.
Enrollment of children as young as 5 between the ages of 2 years and 11 years of age are happening, I think, beginning this week.
Okay.
So the data will be accrued. The approval may take longer in that you're going to have to look a
Wait
little
a
bit more
while.
closely
Exactly, right.
to make sure. Now, your point that parents need to get their kids back to school, many as districts have already opened. We know we can do that safely just using what we know works already.
Exactly.
Masking, hand washing, distancing 3+ feet or more in the classroom, some degree of ventilation, symptomatic screening. Some schools have integrated screening. The good news is that 12 to 16, that's an important demographic in that in certain states like Michigan, there's evidence that that's the age group that's sort of the leading edge of the epidemic now, particularly the circulation of the B117 strain. That may have been the group that in certain states it's driving the transmission
that's what I was
through
gonna ask.
maybe
Okay.
organized sports, maybe not playing on the field, but what goes on after games and the sort. So that is going to get there perhaps just in time to prevent that spread. Also, older children we've known are more likely to transmit and the balance gets sicker than the younger age group. So that's the good news. We may have to wait until early to mid 2022 to get enough data and approval for the younger age groups.
Okay, which makes sense. And that kind of brings me to transitioning to multi-generational households. And that has been an issue since day one, right? It's like grandparents separate, if you can, different rooms, what have you. So now we have, let's say we have a 2-year-old and then a 6-year-old and and let's say from 2 and above, soon, I know that's not a word, but say there's a brand new baby, a couple of elementary school kids, mom and dad, and then grandma and grandpa, and maybe even a great grandpa or grandma in there. What is the advice now from the medical field? And maybe it's the same advice going forward with, let's say most, if not 80% of the households vaccinated, but there's a couple that aren't. You were talking about the spreaders of the age groups, so that's something we can bring in too.
Yeah, so there's a lot to unpack there in terms of the different age groups. Again, what we know is what we know. We know that if you're going to be together with people from other households, people that you don't live with, you really have to respect the social distancing and masking. And that would include relatives as well, if they're unimmunized. If you have a group of adults, 16 and over, that are all immunized, you can probably get together safely, even indoors. We know that the vaccine protects against severe illness and disease. And now we know from real world evidence, I, for example, have 2 doses. I'm more than 2 weeks out. You've been vaccinated recently after 2 weeks.
Next Wednesday is my second one.
Your second dose.
Yes.
So after 2 weeks, the evidence in first-line responders that were looked at systematically for infection after immunization, after a single dose 2 weeks out, you're about 80% protected. After the second dose 2 weeks out, you're about 90% protected against asymptomatic shedding. So that's very encouraging.
Talk about that. I'm interrupting you because that's talked about a lot and it's never explained. Against asymptomatic shedding. Describe what that means.
With most infections, with most viruses, we can be infected and we never know it. The majority of kids at some point over a couple-week period are going to have maybe what's called a rhinovirus or some other common cold virus, and they may not show any symptoms. This is hypothetically possible with COVID. We want to make sure we don't create situations where there are people that could be carriers of it that could pass it to people that are vulnerable,
Exactly.
in particular the elderly. So going back to your question, if you have a grandmother in a household that's 90 and for whatever reason they're unimmunized, you don't want to expose even somebody that's vaccinated. You want to take that precaution until we know more about how the vaccine is effective at preventing that transmission.
And it's nice to validate the fact that this is a new frontier. So there are answers that we have, and there's a lot of answers we don't have, and we just need to respect that that's the case, and it's just simply going to take some time. So here's a question, and it's almost like opening up Pandora's box. The question is, what kind of things can I do now that I'm vaccinated? And we can look at, I like how you were putting into stair steps the different ages. Maybe we can look at, and let's say it was the first group of 65 and over, and let's say they have a bridge group or they have dinner club or whatever. If everyone is fully vaccinated, meaning a good 2 weeks after their second vaccination, Is that something that, oh, now we can convene again? I don't want it to be a controversial question, but it's the questions that everybody's asking.
Yes, and the CDC has given guidance that families that are fully immunized can congregate without masks indoors. Should it go for a bridge group? Again, CDC guidance isn't fully there, but I think that's where we're headed. There should be a modicum of reassurance around that. If you can do things outdoors, that might be more acceptable. But yes, if everybody's immunized, I think you can assume there's a very high likelihood that everybody's going to be safe. And this is assuming that mRNA vaccine, the Johnson & Johnson vaccine, the post-marketing or real-world data isn't quite in yet on the transmission or the infection data that's available for the mRNA vaccines.
Okay.
But it may move in a similar direction.
So we can look at, since people can see you and I sitting together, we're 6 feet apart, 5 feet apart. I don't know. How are we? I'm sure we're 6 feet apart. So I have my second vaccine April 14th. May 1, if we're doing this program, would it be appropriate for you and I to sit here without masks on doing this show as we're talking really loud to each other and all those lovely particles are coming out of our mouth?
Yeah, barring the emergence of variants that could not be, if you will, countered by the current vaccines, yes.
Okay, that's a good idea. I like that. So we covered the vaccines. So the things that, and I know I'm going to go back to sort of the beginning when you were talking about being involved in years of preclinical vaccine development. What are some of the things that are actively being learned right now? And I know you covered some already, but you're that guy that's watching all the studies and watching all the reports and all the research. What are we actively learning right now, or your group learning right now with that?
So we've always known that immunization of a mother can translate into protection for her infant. For years, we've been recommending influenza immunization during pregnancy because we know that that can prevent hospitalization and severe illness in their infant because the antibody is passed across the placenta.
Right.
Going back to your scenario of the multi-generational house, there's a newborn baby. Potentially that baby could be protected if the mother's immunized. Now, the guidance on that, it's not 100% shown to be safe. However, the risk-benefit analysis shows that the benefit is probably in the favor of immunization for pregnant women, given that they may be at risk for complications from COVID above and beyond other non-pregnant populations. Their infant also probably gets the benefit of that passive immunity. So that's one thing that's being learned. The vaccine's going to be studied down to 6 months of age. Is that the lower limit? Perhaps not, but for flu vaccine, we know that they're not very effective before that. That's probably where we're going to settle. So I think based on the evidence of other vaccines, that's how this is going to pan out. We've also known that the HPV vaccine, for example, it's intended to prevent HPV, which is often sexually transmitted. But the younger you give it, the more effective it is. If it's given at age 9, you get an antibody titer that's much, much higher than if you wait until age 11 or 12.
Okay. And that makes sense to me.
Yeah.
You hit on something, too, that was kind of interesting. So and let's just talk about flu vaccine. And you know what? Take a drink of water, because I know you keep reaching for it. We're all about acknowledging the obvious on this show.
Yes.
And I'll just take a really long time to ask this question.
Go ahead.
So 6 months and younger, the flu vaccine, you said, isn't necessarily always works as well as someone 6 months and older. Why is that? If you have that answer.
Yes. I mean, part of it is the development of the immune system.
Okay.
Infants don't respond as briskly to certain proteins, certain antigens, certain viruses.
Okay, that makes perfect sense. The whole idea, and we discussed this a little bit, as people are getting vaccinated, there is the now more brave to go out and do things. And I think it's important in our show, too, to kind of talk about, we don't know who all's been vaccinated, going out and having a big birthday celebration, either at somebody's house or a restaurant. Where are we now? And let's look at, today is April 8th. Today is April 8th, and what we see in El Paso with vaccines versus other parts of the world. Again, we're pretty okay. What is the advice from you as a doctor on those kind of gatherings?
It depends, again, on what proportion of people are vaccinated. And I think at large gathering, whether it's going to be going to a Chihuahuas
Right,
baseball game,
right.
even with a partially full stadium. Until we get to a much higher rate of immunization overall, that's probably not going to be safe, and it could lead to spread of virus. This is what's been seen in other states, again, going back to schools that have competitive sports where teams have been traveling or congregating. That's where spread has been occurring in the school situation. We have to be mindful of that.
We touched base on, and it kind of goes with this too, and you know I always have a hard time saying this, immunity. So herd immunity. We've been hearing about that since day one. You know, there are theories about this and that and the other. If you can explain that to the audience, and maybe even the myths around it, so we can kind of understand where vaccines come in, where no, just let everybody get it and they'll be fine, antibodies, etc. Explain the different myths and the questions that you've been getting over the last year.
Okay, so herd immunity basically is the proportion of people that need to be immunized to cut down on the transmission of a virus. For measles, we know that 90+% of children in a school setting, for example, need to be immunized to protect against measles. Most school districts are up around 95, 97% because of the requirement for immunization before school entry. We don't know yet what the percentage will be for COVID, but it's probably going to be around the 70, 80+% range before we can say we can begin to reopen more, we can begin to relax some of the restrictions in place in terms of indoor dining, wearing masks, etc. Now, if we don't include children in that, children less than 18 make up about 22% of the population. Add to that the adults that may be hesitant, let's say, about getting vaccinated, and you're not going to get anywhere near that 70% either.
You expressed in a point that we have nowhere in this paper, but I work for the El Paso Community Foundation. We have proactively put out a vaccine hesitancy PSA, public service announcement. I would love for you to talk about vaccine hesitancy, what our rate in El Paso is compared to others, but just as a doctor, this is a place to just throw out the sales pitch.
Okay. I think we've known since the vaccine became available that the risk of dying from COVID was about 1 in 1,000 cumulatively. The risk of getting even a minor, what could be construed as an allergic response to the vaccine was about 1 in 1,000 as well.
Okay.
So as you put it, the benefit to you for getting that, the smaller degree of pain, it's way up here. So each of us has to do that sort of risk benefit.
Right.
We have to know as well, we must trust in the science. We must trust in this process. The whole EUA mechanism, it's for the greater good. It's for the public good. This is an emergency, and we have acted accordingly, and we have the data showing wonderfully that it's highly effective, the mRNA vaccines and the Johnson & Johnson vaccine, and they're safe. We can quantify even the severe anaphylaxis reactions. All vaccine centers are set up to treat that. It's going to be 1 in hundreds of thousands where it can happen. We know it happens within 15 minutes in the majority, and then within a half an hour in almost all. We anticipate what that severe side effect is, so you will be safe getting immunized. Not to be immunized, you're continuing to expose yourself. If you're a parent, think about your child. 40,000 children have lost a parent to COVID.
Yeah. 40,000 children have lost a parent to COVID. Now that's a number. On that note too, I do want to give out the information in case you have not registered for the vaccine yet and you'd like to. Registering for the vaccine, there's a couple places you can do that. The website is EP, think of El Paso, covidvaccine.com. It's a super easy site. Once you get into that site, there will be a tag on the top. It says register for COVID vaccine. You tag that and it will take you through and you're registered. If you'd like to do a telephone call and try to do it that way, 915-212-1032. And Dr. Fennelly and I, we can kind of walk you through what will happen. Once you are registered, you will get a telephone call or a text or email, whatever it is that it's your preference, and they will say, come to this place at this time. And when you do go, sometimes there's a line. The experience that I've had, and most of the people that I know, you're there less than half an hour. Sometimes it's more. But you get your vaccination, and they do have you sit for 15 minutes. If you would like to sit for 30 minutes, just to double check. There's a space, it's social distance. It is so organized. Good job, El Paso medical community. Super duper organized. And again, if you would like to do it, I'm going to throw it out again, epcovidvaccine.com. It is a big decision, we get it. And it's one of those things that when you talk, and I like when you say risk-benefit analysis, the risk-benefit analysis, and it goes back again to this herd immunity that we're talking about as well. Got a couple of questions here from the audience, and I have not heard this, but again, I want to respect this question going forward. From the audience, the question is the vaccine only good for 6 months? I have not heard that, but that's the question. Well, we have to get the vaccine every 6 months. Let's just say on my end, extending that, is this something that we would get every year going forward, like the flu vaccine?
These are both great questions. The real world data that I talked about in terms of the 80%, 90% after dose 1 and 2, that was relatively short. There was another paper published this past week that showed that after 6 months, the antibody titer remains very, very high. Great. After the mRNA vaccination.
Okay.
Now, it begins to drop more rapidly in the older age cohorts. The other question is, the other sort of secular trend is, we have the emergence of these variants of concern that may not be fully neutralized by these vaccines. If those evolve more, then yes, there might have to be a new vaccine that will cover them. So that would be the rationale for annual boosting. Also, by just boosting with the same vaccine we've already gotten could also go a long way towards enhancing protection. So this is in the category of we don't know yet. In time, I do anticipate this being like annual influenza immunization.
Okay, and that makes sense. Since part of your specialty, you were talking about you're an expert in pediatric infectious diseases, and you brought up the variants, and I think that's too, once the first variant's like, oh my, and then there's another one, and then there's Brazilian, there's this, there's that. Without freaking everybody out, explain what the mutations were the words used sometimes, variants, explain what is happening physiologically, I guess, with a strain, and how these other strains come about. Just one day it pops up. How does that happen?
Right.
How does another one pop up just one day somewhere else?
Likely when the virus enters an individual, the immune response will select out in a way. The virus that is passed to the next person will have changes in its surface protein that allow it to avoid neutralization by that previous host. That's how we
say
get
that
there.
again. Sorry, explain that again.
A virus enters your body.
Right.
You have an immune response.
Right.
Certain viruses are going to survive that immune response because they have changes in their surface protein that are targeted.
And those changes occurred how? Because there's already something entered into your body previously?
So changes, or what is referred to, or variation, is part of biology. These are viruses that are sort of messy in the way that they make copies of themselves. HIV is even messier. And within an individual with HIV, you could have millions of different variants in one individual. Here, it's probably a lower number of variants, but these variants that just sort of happen and then are selected through immunity shutting down those that sort of pre-existed or they were pre-exposed to, or that immunity gives us protection against these sort of escape variants can get out in time.
Okay. So we are, just realistically, to expect several more variants, and maybe even annually. But again, the boosters are, eventually we'll get to a point.
Yes, so the race now is between vaccination, getting the highest percentage of people within the shortest amount of time before the variants spread too broadly or until they vary even more.
Okay. That to me is fascinating, how all that works out. Question from the audience: what are the ingredients in the vaccine? And I know that you talked about, there are two different types. There's the mRNA, so the messaging RNA vaccine, and then also the adenovirus messaging. So that's a big question.
Right. So messenger RNA, it's simple, just the message, which we have RNA in our bodies, and it's sort of encapsulated or covered in a lipid biolayer. One of those compounds is called PEG, and that might be one thing that can induce allergy in a small subset of individuals. Adenovirus, it's a virus that really doesn't divide itself. It is just delivering that message.
Okay.
And that's the efficient part of these vaccines. They get the message into the cell where it belongs.
Okay.
So they don't have a lot of extra chemicals or adjuvants. There could be certain preservatives, but if you have a known allergy to any of them, you should not get immunized, but we don't know yet.
Okay, and that was, and I don't want to blow that up, but if there are people that, and there are just some people that are allergic to everything. You and I both know that person, or those people.
Right, but we have to distinguish sort of the common allergies
Yes.
to this very rare, it could be predicted if you've had a severe anaphylaxis to an antibiotic or an injection, you want to tell the vaccinator.
Okay.
You may want to be observed for 30 minutes instead of 15
Okay,
minutes
gotcha.
afterwards.
And I'm thinking the peanut allergy people. You know, it's like that. I feel like that's something that we've been talking about
no
for 10
evidence
years.
we know what we know, and we know those that have had anaphylaxis. Peanut allergy doesn't
I bet you're
predict
sick
it.
of getting all these questions that we just
Not
don't know
at
the
all.
answers to.
Not at all.
I'm reading this cold. Caller question says, caller said that they are taking prescribed, oh, listen to that, right in our topic. Caller said they are taking prescribed allergy medication now, Singular and Levocetrazine, and are getting the COVID vaccine Saturday. Good for you.
Right.
Should they not be taking the prescribed allergy shot or medication now while getting ready for the vaccine? So I'm glad that you were listening to what we were talking about earlier. Great question.
That's a really good question. I would encourage them to consult with their doctor. I'm not exactly sure why they're on it. Is it just sniffles that they get, or is it something more severe? Hypothetically, could it interfere with the vaccination? Very small chance, so it's probably okay, but that's the category where I would encourage them to talk to their doctor.
And sometimes we're here because they don't have access to a doctor.
Right,
so
right.
just in case they don't, if it's and let's kind of look at the differentiation there. If it is an allergy type medication for the pollen that's in the air in the spring, then maybe it's not going to be a big deal. So that's something that we want to talk about. We talked about this a little bit, but I want to go into it a little bit more. As people are getting out, and again, adults, and let's just say everybody above the age of 16 is vaccinated. And let's talk about birthday parties. I feel like that's the easy thing to do. We're all Paso, everybody wants to get together. And now you're going to a birthday party for 7-year-olds. Do you go as an aunt and uncle? Is it better not to go? And again, aunt and uncle is vaccinated. How, and I know we've kind of asked that question already, how does one navigate that when you know there's a group of kids there?
Right. I think part of that would be, how old are they? Do they have underlying illnesses? Was the vaccine effective in them? Are they fully immunized? Has it been the full 14 days after the second dose? If one or the other is immunocompromised, the vaccine isn't protecting them, then it's better to avoid it.
Okay. This is a great question. If you've had COVID before, do you need to wait to get the COVID vaccine? That's a whole subset of questions we haven't talked about yet.
Yeah, and I'm
Let's
glad
talk
somebody
about that.
asked the question. When the vaccines were first available, the guidance was wait 90 days. Now there's no reason or no rationale to wait to get vaccinated. You can anticipate, on the other hand, that you've had COVID relatively recently. The side effects may be enhanced, so anticipate that.
Okay. Let's talk more about that. Let's talk about, yes, you had COVID, you're now recovered, you're fine, and then there's the very unfortunate group of long haulers that have just residual symptoms, residual issues going forward. And maybe it's just something as simple as my headache won't go away, or the aches and pains won't go away, or I'm just not breathing the way I used to. When they're looking at that group, and let's hope that they are with a doctor that they're consulting, but let's say they're not. Do they look at getting the vaccine anyway, even if they're continuing to have what they may seem to think are long hauler symptoms?
So to respond to that, first, the vaccine will not give us COVID or will not expose us to the virus. It's a very small part of the virus that itself doesn't infect. Second response is there's emerging anecdotal evidence that after vaccination, certain long haulers or people with long COVID feel better. So that's something that needs to be explored more. What's the basis of long COVID? It's probably not persistence of virus per se, but it is possible, based on this, what's thus far anecdotal evidence, that it could improve.
Okay. Okay, so now let's talk. There have been people that have had COVID twice. Same situation there? And I don't know if it's something that they're more susceptible, or they're just in areas of work where they're able to, get it a couple of times. And I'm just asking because I'm about at the point where I'm just going to say anything that you want to say that we haven't talked about yet.
So the reports of reinfection, with few exceptions, if any, have been asymptomatic or have been
really?
very, very
That's
minor.
good to know. Okay.
So there have been few reports of 2 courses of very severe COVID. So recovery from COVID is tantamount to pretty good immunity against severe disease.
Oh, what a lovely thing, right? I really like that. Take your drink, because this is a perfect time for me to give out the information again. And yes, he's got vodka in his cup, in case you're wondering. But again, if you are interested in registering for the COVID vaccine, you haven't done so yet, that website is EP, think of El Paso, COVIDvaccine.com. Sorry, I'm in Zoom meetings all day, so I'm looking at the screen versus the camera, my apologies. But again, EP, COVIDvaccine.com. And if you want to dial a telephone number, you will be on hold for a little while, but the telephone number is 212-1032. And if you just want simple information on what's going on, up-to-date information, daily information on what's happening with COVID around the region, you can always go to the El Paso Strong website, and there is an area on that website that talks about what's happening with COVID. You can also register there. You just have to kind of look around a little bit. But again, the COVIDvaccine.com, epcovidvaccine.com website has the registration right there. Question from the audience before I just let you loose, so to speak, because there's going to be a point where I'm just going to have you talk about everything you want to talk about before you got here. Is aspiration performed with the COVID vaccine? Sorry, I read that cold. I don't know exactly what they're asking.
Aspiration performed.
That doesn't make sense.
I'm not sure. I mean, I'm not sure technically. When you insert the syringe that filled with the vaccine solution, we will pull the plunger back to make sure that we're not in a vein, which is a very rare likelihood.
I see.
That may be what they're asking.
Okay.
And I have to say, I myself have volunteered to vaccinate at Texas Tech. As you said earlier, this community has done a marvelous job stepping up, getting it to the elderly, getting it to everybody. The students have been volunteering, faculty, our president and dean at Texas Tech has volunteered. So they're all very good vaccinators.
They're all very good vaccinators. I like that. Everybody can line up and learn how to give a shot. So here is my question to you. I know this is full of information. We've covered so much. But let's talk about what we haven't covered, that you've been getting asked questions for, just in general, your thoughts. We've got a good 15 minutes to fill up that spot, and I just really want to hear from you as a person who's been doing this for years, developing these vaccines for years. All of us want to sit at the dinner table with you. So now is the time just to talk to us.
Very good, very good. Well, aside from the work I've done, the objective there is to get children immunized at the earliest possible time after birth. Measles is still a public health threat. We've had outbreaks in the US. It's still a major killer. The vaccine doesn't work well in young infants, which is why we started looking for alternatives to protect the most vulnerable. The biggest threat to immunization in general now is vaccine hesitancy, as you pointed out. Before the pandemic, it was identified as one of the greatest threats to public health by the World Health Organization. So it's very important that we learn how to engage.
Right.
We need to trust in our leaders. We need to trust in our process. The FDA is one of the most thorough, ethical in everything that they do, authoritative bodies in the world. These vaccines would not have been approved for EUA unless they were found to be safe, most likely, which we know they are, I believe, within certain parameters, and highly effective. So it's a matter now of engaging communities that might be averse. It's interesting, what I've learned is, my assumption would be that most people would want the mRNA vaccines because the perception was they're more effective. Certain people just want to get it over with in one dose. So how do we engage people? What's going to work best for you? How do we get the vaccines to the people that need them? Maybe we want to supply more of the Johnson & Johnson in certain areas. We need to also make it much easier than it's been. In time, I want it to be as easy as going for your flu vaccine at your local pharmacy. And we're getting there, and we're getting there fast. So that's what really encourages me.
I like when you said just getting your regular flu vaccines. just being in a Rotary Club, for example, there'd be that day, Thursday, October, whatever, and at that time, VNA or whatever, they just go, get your flu vaccine. And there wasn't pre-registration. At the end of the day, you're taking a questionnaire, so to speak. Do you think that we might be there, and I'm going to say by, let's say 2023? Let's skip 2022 and that question, because again, there's so many unknowns that, and I know this is pie in the sky, future, glass ball looking at, but what are your thoughts about that?
No, I think by 2022, early to mid, we're going to have approval across the lifespan for COVID vaccines in the U.S.
Okay. In the U.S., and that's a key point, because I was going to ask you about global in a
yes,
moment.
So questions are going to begin to emerge. Should it be required for school entry the way measles vaccination is, chickenpox vaccination? Many states are now insisting on flu. And in terms of the threat to children, flu virus kills upwards of maybe 180 children a year. That was a banner year for flu. COVID has surpassed that. There have been 280 deaths due to COVID in children. We have to be mindful of that. And also to protect the teachers, to make sure that all families feel safe in those environments. It's going to be important that everybody be vaccinated. So should it be a personal choice? To a degree, it should be. But I think jurisdictions are going to begin to look at that. States have the authority to mandate vaccination for school entry. Hospitals can have the authority to mandate that their staff be immunized. And many, I think, institutions are beginning to look at that.
I'm glad that you brought that up, and we try in every way, shape, or form not to be controversial on the show. But that, again, you talked earlier, this is public health. This is for the greater good. Does the end justify the means? I'd like to take that thought process, and now we are in America. It's one thing. Right across the border, we're having a bit of a harder time distributing, getting supplies. As I said before the show, all of my family, aside from my immediate family, all of my family is in Western Europe. And when I got my vaccine, I took a little picture of my arm and they got mad at me. It's like, oh, don't be a show off. Globally, and maybe we can talk about travel, maybe not. I'd like to kind of stay on the public health spectrum. What is happening globally? And you even joked about, not joked, but one of the vaccines that we're getting in America so easily is actually developed in Germany. That's where most of my family's from. How does that work? Like, I know you purchase a vaccine as a country. I feel like I read about it differently, and I'm not sure how it works myself.
I think there were a lot of wagers that went on early on. With the mRNA vaccines, the U.S. government contracted with both Moderna, Pfizer, BioNTech, Johnson & Johnson, AstraZeneca to a degree. The rest of the world invested very heavily in the AstraZeneca approach. It was really designed in certain ways to be an affordable vaccine that didn't need the cold chain for storage. There was a lot of hope there. Unfortunately, it hasn't held up well against certain of these variants. There is the Serum Institute in India that was ramped up to produce a billion+ doses. So the production is there, it's affordable, it's being distributed through COVAX, which is an international organization that gets the vaccine to less developed countries or at a cheaper rate. So Mexico can get it through that entity, South Africa. So there was great hope there that that would be the vaccine for everybody. Unfortunately, we're not there, and I think there's opportunity to develop a newer version of that that could be more effective, but that's going to take time.
Okay. And when you say, so talk about COVAX, because one of my favorite, I just love Al Jazeera and BBC. Again, I consume international media, and I hear about COVAX a lot, but it's a great organization. How are they receiving their funding? Do people donate? Do organizations, do companies donate globally to this? How is that working?
I mean, all of the above. It's governments, and the U.S. government has stepped up more under the Biden administration to contribute to that. The Gates Foundation, Gavi is a similar organization that sort of houses COVAX, that is an entity that really makes vaccines accessible against childhood diseases. So when we hear about measles vaccination, polio eradication, it's Gavi that is facilitating that.
Okay. So I'd like to talk about the compromises, as people would say, the underlying conditions. And you said earlier, too, and it's not an alarming number until you look at the whole idea. It's like, oh, kids are immune, kids are immune, kids are immune. I know we're past that idea that we definitely want to get kids vaccinated, not only for themselves, but for people around them. But talk about some of the issues that children have if and when they contract COVID. And one of them that we've talked about before on this program is MIS-C, the multi-system inflammatory syndrome in children. Because for the longest time, it's like, oh, the kids are fine. The kids are fine. Don't worry about them. But they're not fine. And I'd like to explain that a little bit.
Okay, so when thinking about COVID in children, first of all, cumulatively, there have been 3.5 million cases reported. We know that children, like adults, can have long COVID. So in a cohort in the UK, they've observed long COVID, what they're calling based on lingering symptoms for 5 weeks or more in 10 to 15% of children recovering from COVID. That's one part of it. 1 in 50 hospitalizations are in children. I mentioned the statistic of 280 deaths, which far exceeds any deaths due to flu in a typical year in children. And the MIS-C, there have been upwards of 3,000 cases now. It can happen to anybody regardless. It really, there's no known predisposing factor. It can lead to hospitalization. It's killed dozens of children. And it can have long-term sequelae in terms of effects on the heart, the kidneys. We don't know if there are any neurocognitive impact of that either. So that's another very compelling reason that we get everybody vaccinated.
And everything's growing, you won't know right away. Question from the audience, and again, this is a media thing that everybody's hearing about. Has blood clotting been associated with COVID vaccine? Again, there's a lot around that, and the start, stop in Europe and other places too. Explain from your point of view and globally, because that's what we're hearing, the start-stop situation, and why that is happening.
Right. So is there an association? It's not clear yet. Is it causal? We certainly don't know that. There have been several reports, and as you point out, there's been a lot of stopping and starting. Most analyses have shown that this happening in this percentage of individuals is no higher than it would have happened in the absence of vaccination, as much as I know of as of right now.
Okay.
Part of it may be, you certainly remember when you got vaccinated. I remember when I got vaccinated. It's a huge event. And then something happens in the wake of that. Do we attribute it to the vaccine? That may be what's happening here.
I just wanted you to explain that, because that's my thought process as well. Question here from the audience just came in, reading this cold. When do we need to think about getting the vaccine a second time? So we talked a little bit about that. We're not sure yet, but let's
meaning
let's
a
go
second
there.
time, meaning you got
Like,
your
say
2
we're
doses.
fully vaccinated this year.
And
Is it
again,
a- yeah.
so the studies that are happening now are looking at two main questions. With the variants, for example, is it sufficient just to give another dose of an mRNA vaccine, for example? Will that give us an antibody level and breadth that can neutralize these variants? Or do we need to come up with a new strain? So I think Moderna is well along in terms of coming up with a new messenger RNA sequence that reflects
This
the
new strains,
variants.
some new
So
variants,
they're going to
okay.
immunize in well-controlled studies, take the blood from the individuals and ask the question, how well will that neutralize in vitro?
So you doing what you do in development of vaccines, again, this is where it's fascinating. So you're talking about now getting vaccines, they're going to have a little bit of a different formula to them for the years to come. And again, like flu, and like talked about flu vaccine, because every year you get a flu vaccine, it's not the same flu vaccine you got 2 years ago or 3 years ago. There's a little bit different each year. Am I correct when I say that?
Yeah, they're up to 4, in any given year, you may get up to 4 different flu variants, we can call them, or strains in one injection.
Okay. And the reason I'm asking that is that it would be very normal and very expected for this to be with COVID. And I guess my question too would be now, would it be ever a point where you get the flu vaccine and it's combined with the COVID vaccine, so it would be one vaccine that you receive once a year?
It's unlikely, again, for the reason that it's potential for them to interfere. We want to allow the immune system to luxuriate in exposure to flu for a while, recover, and then we'll expose it to COVID. That's generally
Luxuriate, I love that.
We do, I mean, in children, we do combine up to 5 different, what we'll call antigens or proteins into a single immunization. Otherwise, children would be pincushions with the number of vaccines we give nowadays. We know that these vaccines are safe beyond just the pain of the injection and the swelling and redness they get afterwards. We know that there's not much other risk.
I was on a meeting today when, and you old timers, if I say it that way, but I'm an old timer too, but back in the day, I don't know, have you been in El Paso all your life?
I arrived in August of 2020.
You won't remember this
From New
then.
York City.
I have to give a nod to Dr. Lawrence Nicky. And there was the vaccine campaign, 2, 4, and 6 months, El Paso, Juarez, and Las Cruces, and it was all about those months or
Those
when your babies
routine
get vaccinated.
Yep.
The reason I bring that up is that you said, and I remember my little ones, it's like, wow, they get 3 shots today, and next time they get 2 shots. And I remember thinking to myself, how is the body dealing with all these? So taking what you just said into that idea with young ones and now going forward with the other vaccines, because I know, for example, when my kids went to college, they had to now get the meningitis vaccination as well. So it's beautiful that these are all happening, but I would love for you to explain how, again, physiologically, your system is dealing with 3 vaccines at a time.
We can be reassured in the balance that our children are being exposed to fewer vaccine proteins than they were in the era when we all got smallpox vaccine. So smallpox, just a single dose of that will expose you to dozens of different proteins. So children are not being exposed to more proteins. Also, a lot of attention is paid to safety now that wasn't paid 50 years ago.
Exactly.
And we also have to ask, what's the alternative?
Right.
As a medical student, I went down to Nicaragua in the early 80s for a rotation, and I needed a flu booster because polio was rampant in Central America.
Yes.
So to me, the fact that we are on the cusp of elimination worldwide is a thing to celebrate. I've
really
seen
is.
children die from measles in New York City in the 1990s, younger infants that were too young to be immunized. So it's a dreadful thing, and
Right.
that's why as a community, as a society, we owe it to everybody to be responsible, get vaccinated ourselves, get our kids vaccinated to protect the most vulnerable. Those that may not be able to get vaccinated against COVID, those that are immunosuppressed that may not respond to the vaccine.
And again, it's again all about reducing the risk worldwide
Yes.
and countrywide, citywide, household-wide, etc. Again, if you have not registered for the vaccine and would like to, that address is EP, El Paso, just think of El Paso, epcovidvaccine.com, number 915-212-1032. If you only caught part of this program and would like to catch the program again, you can go to www.pbselpaso.org. You can also find this on the El Paso County Medical Society website, and that's www.epcms, just think of El Paso County Medical Society.com. You've been watching a very informational show. Dr. Glenn Fennelly has been with us this evening. Thank you very much. You've been watching the El Paso Physician. I'm Catherine Berg. Good night.